So if people want to click on that green box that's bumping the center and the knees, that will give you information for.
Mm-hmm.
And Lucinda, you'll give me the thumbs up when you're ready for me to go.
I will. Okay, because I want to make sure that Jackson is here. He's supposed to be, let me see who's here. Jackson. He is, yes, he is. He is going to be
Yes,
live streaming you, and is that correct?
we are already streaming, yes.
Okay, you're on already, Gentle.
Yes.
May I start then?
Please go.
All right, thank you. Okay, I want to say hello to everybody. Welcome to this presentation about proactive health, and I want to thank Lucinda for inviting me to share with you today. I'm going to start off with my standard disclaimer. I am not a medical professional. I don't even role play one in Second Life. I am an educated consumer of healthcare, and I continue to educate myself because new information is always becoming available. You will notice that I am a retired educator. Teachers never really retire. We just teach to different audiences. So I'm also going to warn you that I'm convinced I could do a whole hour session on any one of the topics in this presentation. And I'm going to try not to talk too fast at this session. I've omitted half of the presentation I originally made. I'm leaving out bone health. There's nothing about brain health, oral health, cancer, falls, shingles, substance abuse. Those all I could talk about, but I'm not going to. May is Older Americans Month. The 2023 theme is Aging Unbound. For more information about that important advocacy opportunity, please click and bookmark this link. And you will find a lot of links in my presentation that you can click and bookmark, and all those links are in the note card that's in the green box. We older folks can be unbound in a lot of different ways. We're freed from some of the worries of our younger lives. We don't have to establish a career. There's much less likelihood of an unwanted pregnancy. We don't have to worry about paying our medical insurance deductions now that we're older because we've retired from our careers. Most of us can no longer get pregnant, and we still do have to worry about our insurance deductibles, at least in the US. Today, I'd like to explore some health issues that we need to be aware of or more concerned about as we age. The information I'm providing today is all evidence-based. I will offer links to articles in peer-reviewed journals that you can click and bookmark for later perusal. If you don't feel like reading them, you might find it useful to click and bookmark them anyhow, because maybe these are things you should share with your healthcare provider. Sometimes I can find easier to read summaries, and I will provide links to those as frequently as I found them. And of course, there's the note card in that green box by Lucinda. So let's get started. Healthcare knowledge changes over time. The goal of healthcare has always been to improve health and quality of life whenever that is possible. Medical professionals have to offer treatments and advice that is based on the current level of knowledge that they have, and it's based on beliefs. And so that means that when they describe what they're working from, they call it best practices. But what is considered best practice has changed over time. On the left, you see a 1920s advertisement for Lysol. Women were encouraged to douche with Lysol to maintain feminine cleanliness. That, of course, was before doctors realized that healthy women's genitals were not supposed to smell like pine, and that the microbes there were actually beneficial. Closer to our own time, women were encouraged to take hormones to avoid the symptoms of menopause. Some of us have been told that by our medical providers. Men took PSA blood tests. Some are still being suggested that they have the PSA test. And those whose PSA readings were showing suspected prostate cancer often had surgery to remove the affected gland. These treatments made intuitive sense, but they had never been tested. In 2002, research showed that hormone replacement therapy, HRT it's called, caused more heart disease and more breast cancer than it protected women from hip fractures and colon cancer. So in other words, the risks outweighed the benefits. PSA screening research from 2009 showed that this routine screening resulted in unnecessary surgeries, often with side effects such as urinary incontinence or impotence. And there was not significant decrease in prostate cancer deaths from the screening. Why do we continue to offer treatments that have dubious benefits and unknown risks? Because we don't know better. And here's a nice opinion piece. It's not a research article, called Testing What We Think We Know. It is by a professor of medicine. And again, there's your link, and you may want to click it and read it. Very interesting. You've undoubtedly heard all about these healthy learning things. What's good for younger people's health is equally good in general for older people. So I'm just going to share a few interesting research studies that you might not have heard about. And something as simple as a few glasses of water can be very beneficial to older people's health, because this is a quote from the research article. Actually, many older people are not properly hydrated. They have too much sodium, and that gives them a risk for being biologically older, developing chronic diseases, and dying at a younger age. And there is the link to that research article. So drink up water. And you also know that as we age, our metabolism slows down, so we need to eat less than when we were younger. But at the same time, our ability in our digestive system to absorb nutrients is less efficient than when we were younger. So our nutrient requirements actually are increasing as we age. And additionally, chronic health conditions that we may have and some medications that we take affect our nutrient requirements. And it turns out that many older people don't get enough protein, omega-3 fatty acids, dietary fiber, different vitamins, calcium, and also many older adults get too much folate and sodium. And I'm going to share that there's a wonderful book chapter that has a modified food pyramid for older adults. That, again, might be something you might want to click and save for later. So respiratory issues, such as these that are on the list on this slide, are not uncommon as we get older. Chronic respiratory diseases, unfortunately, are not curable. In adults, they may be due to environmental factors or to frequent childhood respiratory infections that we had when we were younger. And these respiratory issues can have a significant impact on our quality of life. Lung function is a long-term predictor for overall survival rates. And there is the article from which that quote is pulled. In 2017, chronic respiratory diseases were still the leading causes of morbidity. Morbidity means suffering from disease. A large proportion of the disease burden was attributed to asthma and chronic obstructive pulmonary disease, COPD. And there is that report. Research shows that aging is related to respiratory issues in two ways. First, getting older increases our susceptibility to different kinds of chronic diseases. The risk for developing COPD is 2 to 3 times higher in the elderly than it is in those who are under 60. Also, aging more severely impacts acute lung diseases you may already have, including asthma. And actually, they don't even know why that works, but it is true. So there is that report on the 2 ways that aging relates to respiratory issues. Asthma in aging adults is really problematic. Many older adults ignore the symptoms of asthma or attribute them to normal aging, being overweight, or out of shape, because asthma can develop later in life. Delayed diagnosis of asthma in the elderly can lead to permanent impaired lung function. And asthma was actually reported as the cause of death in 30.7 per million people in the US over age 65. That's far above the proportion in any other age category. Asthma is a killer. And there's some very interesting data charts there from the Centers for Disease Control. Yeah, Kirsten, it is amazing. Flu, respiratory flu, and pneumonia are not chronic conditions, but they do significantly impact those of us who are older because we're less able to fight off infections, and those diseases then can significantly impact our health and our longevity. So how can you tell if you have the flu when its symptoms mimic other stuff that's not quite so bad, such as a cold? Well, one common flu symptom is fever. A fever in an older person generally indicates a serious infection, and often it is a bacterial infection, but I do want to remind people that the flu is not a bacterial infection, it's a virus. But 20 to 30% of us with serious infections don't show a fever. And that's one of the common things that people, including doctors, look for as a sign of infection. Older people also tend to have lower baseline temperatures than younger people. Signs of fever in an older person could be a temperature rise of more than 2 degrees Fahrenheit over your normal body temperature. So you have to know what your normal body temperature is. Excuse me, any temperature in an older person higher than 100 degrees at any point is a danger point, as are multiple temperature readings above 99. And these would not be considered fevers in a younger person. So there's some information about your temperature that's kind of important to know. And I want to make one more point about our respiratory system. You notice I had a little cough there. Do you have a persistent, hacking, dry cough, non-productive, but you don't have any sort of respiratory condition or infection? That cough just might be a side effect of a prescribed ACE inhibitor. Lisinopril, I'm talking about you. These ACE inhibitors are often prescribed to treat high blood pressure or heart problems. And it's really important to read the small print in the little pamphlet that they give you along with your pill bottle, because side effects are not always in the same biological system as what the drug is treating, and they can impact your quality of life. And there is an article about that. I hope that helps some people with coughs. Helps if I don't push the teleport button. We need to remember that all our body systems are interconnected and they affect each other. So weight gain and obesity, all age groups have this problem, but it's one that we need to be aware of at our age. It is definitely a risk factor for lots of systems. It impacts arthritis, diabetes, heart disease, high blood pressure, and stroke. As you age, you're losing muscle mass, you become less active, and you actually burn fewer calories than you did when you were younger, even when you're doing the same physical activities. So BMI, body mass index, is a measure of obesity. And I know many people don't like math, But here is a calculator to help you find your BMI. You put in your height and your weight. You can use either standard or metric measures, and it will compare you to the categories. I will point out in the US, almost half of men and women over age 60 are considered obese. That's not good. There is the calculator. So you don't have to do any math, just put your numbers in. One of the best ways to lose excess weight is physical activity and exercise. And there are some suggestions there because we do need to do more exercise. But you may be interested in this study. It showed that obese elderly people have better ADL, activities of daily living, and IADL, instrumental activities of daily living. They score better than people with lower BMIs. So in other words, fat is not always unhealthy bad. I wouldn't recommend becoming fat if you aren't, but if you are, maybe don't worry quite so much. There's an article about that. If you lose weight without trying to lose weight, do please tell your doctor right away. If you lose 5 to 10% of your body weight without trying and you're otherwise healthy, it increases female mortality 114%, and it increases male mortality 289%. So we do need to be aware of our weight and its potential changes. And there is the article for that one. We're going to sneak up on some math stuff here by talking about diabetes, which is not one disease. It's actually several different kinds of diseases. You've probably heard of type 1, type 2, gestational. Type 2 diabetes is 90 to 95% of all the types of cases of diabetes, and it is generally totally avoidable through good health habits. Diabetes can have severe health impacts on many body systems. And unfortunately, if you're not diagnosed with diabetes early, these problems may not be reversible. It can even lead to amputation or blindness. Again, this diagnosis is reversible with good, healthy lifestyle choices. So here's some information on the various types of diabetes, if you're not familiar with that. The CDC writes a lot of things that are more easy to read. So the question is pre-diabetes real? I'm sure some of us have been told by our physicians that we have pre-diabetes. Is it real? Here comes the math. Don't panic. Let's think about some basic statistics. When we say normal or average, what we mean is in the middle area under a bell-shaped curve. And I like this bell-shaped curve because it shows the number of people in each area under the curve. I'm sure you're all familiar with this curve. Lots of people have blood glucose readings in the normal range, and I think that's what you would expect. Some people's normal readings are above average. Some people's normal readings are below average, and all that's to be expected because we have normal biological variations. People whose blood glucose readings are way above average have some form of diabetes, and they need treatment, and they will benefit from treatment. It'll improve their health. But a third of US people are now being told they have pre-diabetes, and this may actually not be a disease. Here's why. The concept of pre-diabetes was developed by the American Diabetes Association in order to get doctors and the public to take diabetes seriously. Very few people, less than 2% per year, who have been diagnosed with prediabetes ever progress to having full diabetes. Slightly elevated blood glucose levels respond really well to healthy diet and exercise. So who is it that benefits from labeling prediabetes as a medically treatable condition? I bet you've already suspected where I'm going with this. It's Big Pharma that's going to make money off of this diagnosis, not you and me. For more information about prediabetes, Science is a well-respected journal. Please always beware of medicalization of normal health variants. New York University Med School has a very easy, readable discussion of that. Heart disease, and now that we'll talk about that. This is the number one killer of those of us who are over age 65. As you age, your chances of developing cardiac diseases or having a stroke increase due to risk factors such as high cholesterol and high blood pressure. Healthy lifestyle choices that we talked about before can help. But what about, for example, antihypertensive or blood pressure control meds, such as statins? I'm sure some of us with high blood pressure have been prescribed statins. To talk about this, we have to consider some math, and we have to consider an acronym. The acronym is NNT, and that stands for numbers needed to treat. If the NNT is 20 for a headache drug, that means 20 people have to take the drug in order for one person to be cured of their headache. 19 people will take the drug but won't benefit at all. If the NNT is 100 for a different headache drug, that means that 100 people have to take this drug in order for one of them to cure their headache. 99 people will not benefit from taking this second drug. So these numbers go backwards from what we might normally expect. Higher NNT numbers mean the drug affects fewer of those who are taking it. The larger the NNT, the more people will not be helped. Stranger, I am afraid I have to agree with you. So let's look at some numbers here. This is the data for statins given to persons who are at low risk for heart disease. There is absolutely no evidence that lives were saved in this group by taking statins. No evidence. On the other hand, they did help one person out of 217 avoid a non-fatal heart attack. And they did help one person out of 313 avoid a non-fatal stroke. And those are good, right? Because we don't even want non-fatal heart attacks. We don't want non-fatal strokes, right? So that sounds pretty good. It's helping people. 92 million people in the US were taking statins in the year 2018 to 2019. That's where I got this data from, Science Direct. You can check my math later if you want. Dividing that total number of people on statins by the NNT shows us that 424,000 people avoided a non-fatal heart attack, and almost 294,000 people avoided a non-fatal stroke. That sounds like statins are doing a good job. They didn't help the mortality, but they helped non-fatal heart attacks and non-fatal strokes. However, there are always side effects of medications, right? We've said that before. So now I want to talk about the harms of NNTs. And these are the harms of providing statins to people in the same group who are at low risk for heart attacks. One person in 21 taking statins, one out of every 21 people taking statins had heart muscle damage that caused them pain. One person out of 204 taking statins when they weren't at high risk for heart disease developed diabetes. Totally different body system. So that means that almost 4,381,000 people developed cardiac pain from taking statins. And over 450,000 developed diabetes from taking statins to help their heart. Far more people were harmed by this therapy than were helped. And we would not know this if there wasn't research studies being done to help us understand the NNTs, numbers needed to treat, of both benefits and harms. So, do you want to learn more about NNTs and statin therapy for heart attack? Oh, the FDA is reading that. Statins given for 5 years for people with heart disease, known heart disease, that gets a green light for effectiveness, according to NNT research. And there is that research. So if you have known heart disease and take statins for 5 years, it will help you. But statins in persons at low risk of heart disease, the 2 slides that I've showed you already, gets a red light. Should not do it because it's not going to help. There you go, Shiloh. And there's the information about why people at low risk don't benefit from statins. How about aspirin therapy? How many people have been told by their doctors they should take a baby aspirin every day to prevent heart disease? I remember that was popular a few years ago. So, aspirin for preventing a heart attack or stroke gets a red light. And it is still here, Margaret. That is right. So there's the research why aspirin really doesn't help you prevent a first heart attack or a stroke. But if you get aspirin immediately after you have a major heart attack, that is very effective. That's where you need to take your aspirin. That gets a green light. And there's the research there. So the NNTs for benefits and harms are really important pieces of information when you're trying to weigh the benefits and risks of therapies that are being proposed for you by your medical professionals. And they don't even measure the cost of the money that's spent by people who do not receive any benefits from taking the drug, but those people are still running the risks of the various harms. Yes, there's lots of liver problems involved. So let's talk about something a little more fun. Let's talk about sex. Sexuality remains integral to the quality of life of older people, and it is important to remember that when you're receiving health care and when institutions are planning services. Although the prevalence of sexual dysfunction admittedly increases with age, studies of sexual satisfaction reveal that only a minority of elderly people experience significant distress about their sexual function. Sexual expression of older adults is influenced by diverse psychosocial and biological determinants, including what we heard from Sage, ageist beliefs about elders' sexuality. And there is a good publication from the National Institutes of Health. That's where those quotes came from. So here's quotes from a different source. Physiological changes that occur with aging can affect sexual function, and they may be ramped up by other diseases that you have, like diabetes. The causes of sexual dysfunction, along with patient preferences within the patient's social system, we're talking about ageism, serve as the foundation for developing person-centered strategies that healthcare providers should be using for us. And there is the article from which that quotation comes. So here comes my caveat. Sexually transmitted diseases, STDs, also known as sexually transmitted infections or STIs, are increasing at our age group because we're sexually active. We have to destigmatize sexually transmitted diseases in the elderly. We have to encourage medical professionals to include elderly people in screening programs. and we need to offer us prompt diagnosis and treatment for these issues. And there is that article. So I hope everyone here can enjoy their sexuality, but my message is please be safe about it. So, what have you got to be depressed about? You can be sexual as long as you're safe. Causes of depression related to aging include loss of functionality, chronic health conditions, disabilities. We see more and more of our family members and friends dying, and increasing social isolation. Depression can change our eating habits, leading to either malnutrition or obesity, both of which are dangerous. It can also disturb our sleep, increase our reaction times, ramp up our memory loss, and decrease our ability to pay attention. Estimates of the incidence of major depression among the elderly who are living independently range from 1 to 5%. That's not too bad. The rate of depression of hospitalized elderly is over 11%, more than twice as much. And for people in our age range who are requiring home health care, it's 13.5%. And that data comes from the Centers for Disease Control. These are good sources of data if you're looking for information. In one study, depression was more common in elderly men than women. The risk of depression increased with their age and with comorbidity with both asthma, well, all three, asthma, diabetes, and kidney failure. There's where that research is reported. Didn't say why women were better controlling their depression. Depression prevalence seems to vary widely. It depends on your dementia status. People with dementia do get depressed. It depends on marital status. Marriage is actually protective against depression, most marriages. And it depends on your level of physical functioning, because if you have poor activity levels, that increases your risk for depression. And stranger, yeah, you might think they would be higher. And there's where that information comes from. Here's the thing, 15% of older people have what is called subsyndromal depression. This may explain why Stranger and Serenity are surprised. These people don't have all the classic symptoms of depression, but they feel less pleasure and interest in the people and activities that they used to enjoy. And therefore, because they're not showing the classic symptoms, they often do not get diagnosed or treated. And medical professionals need to become familiar with an age-specific screening tool, which is called the Geriatric Depression Scale. Most of us are being measured against depression scales that apply to younger people. So this is one you might want to print off and send to your healthcare provider. So there's a difference between alone and lonely. Being alone is a physical state, you're by yourself, whereas being lonely is an emotional state where you feel alone or disconnected from others. You can be alone and not lonely, and you can also be with other people, but still feel lonely. Older adults in the US are more likely to live alone than are older adults elsewhere around the world. 27% of people over age 60 in the US live alone. Only 6% live in an extended family household. That's very different from other places in the world. Older women are more likely to live alone than older men, and that's because they live longer, and also they tend to partner with older men in the first place. And this is from Pew Research. Pew Research does a lot of really good statistical studies, so you might want to make sure you know about Pew Research. 12% of elders living alone have trouble affording their basic expenses. They're juggling whether to pay for food or medical care. They can't do both. Yet 62% of older adults would rather age at home than live with a family member or in assisted living or a nursing home. And there's where that research is published. Loneliness from social isolation is a major risk factor for many physical and mental conditions. It can cause a weakened immune system. It can increase cardiac disease, obviously depression, Alzheimer's, even death. Research is beginning to show that loneliness alters brain structure. And there's where some of that research is. See, all this stuff relates, doesn't it? I like this study. Loneliness may be a bigger health risk than smoking. And we've all been told how much smoking is a health risk. And there's where that research is from. That doesn't mean you should go out and smoke. That's not going to help. Programs to address loneliness among the older population have not been shown to be effective. This doesn't mean that it doesn't help to help older people not be lonely. That would be a good thing. It's just that the programs that are being used aren't working. And there is that article. We need better anti-loneliness programs. And you may want to check out 2 of the poster set displays that are over on Health Info Island this month. There are 2 of them that are about loneliness, and the poster sets are explained in a note card that's in that green giver box. And these are rhetorical questions. We would be here another hour. Perhaps access to the virtual world would help. How can we promote this for the elderly population to combat loneliness? Although we could discuss that. I think Lisanna is probably taking notes on things she may want to have on her next conference. Good old COVID. We're not done with it yet. I know there was an ending on May 11th. We abracadabra, waved the magic wand, and no longer is COVID a public health emergency. But increased neurological and psychiatric health risks are persisting after people recover from an initial COVID infection. We call that long COVID. Oh, that's interesting, James. Persons over age 65 are at a greater risk. If they've recovered from COVID, they're more likely to have long COVID than young people are who've recovered from COVID initially. Also, COVID and recovering from COVID sometimes triggers or makes worse other chronic conditions that you already have, such as heart, respiratory, neurodegenerative diseases, and it also hastens functional decline. Increased isolation during lockdown may have contributed to both mental and physical decline in the elderly. And of course, many elderly are grieving the death of family members or friends. I thought this was interesting. A sizable proportion of older adults who had survived COVID received a neurological or psychiatric diagnosis. And then they subsequently died, especially those who were diagnosed after COVID recovery with dementia or epilepsy or seizures. And this is talking about the time frame of when they had the COVID and recovered, just after, but not just before. Just after Delta came around, there were increased risks of ischemic stroke, epilepsy or seizures, cognitive deficit, insomnia, and anxiety disorders in the elderly. Of course, we also saw an increased death rate from the Delta. With Omicron, there was a lower death rate, thank heavens, but from the people that survived, there were the risks of the neurological and psychiatric outcomes were very similar to with Delta. Interesting that it had a different immediate effect that Omicron caused less deaths than Delta, but the long-term COVID effects were similar. Carers and healthcare professionals should consider the effects of long COVID in evaluating health decline and decreased quality of life of older patients. Yes, it's undoubtedly true that the long COVID is impacted by the conditions of your exposure to COVID. And the Lancet, again, is one of the most highly respected medical professional journals, and there's where they're talking about this. How about all these medical screenings? It isn't always easy to figure out how often you need screenings. So we're going to talk about mammograms. Guidelines for mammography vary. U.S. Preventive Services Task Force says women should get a mammogram every 2 years between the ages of 50 and 74. But they also add current evidence is insufficient to assess the balance of benefits and harms. That's that NNT stuff again. They can't tell if it's worthwhile for women 75 and older to have mammograms. They just don't have the evidence. There's where their recommendation is. If you go to Canada, the Canadian Task Force on Preventive Healthcare says that women aged 50 to 74 should have a mammogram every 2 to 3 years. There's where their recommendation is. And for our friends in the UK, the National Health Service's Breast Cancer Screening Program invites all women from the age of 50 to 70 for screening every 3 years. And they say this means that some women will not have their first screening mammogram until they're 52 or 53. So the recommendations are somewhat similar, but not exactly. No matter when you have them, are mammograms helpful? The Cochrane collection, and this is one that you really need to know about Cochrane. They looked at 10 years of scientific evidence, research, and they concluded that the best research, the best well-conducted research, showed that mammogram screenings did not reduce breast cancer mortality. They also say screening will result in some women getting a cancer diagnosis even though their condition would not have led to death or sickness. Currently, it is not possible to tell which women these are, but those women are likely to have breasts or lumps removed and to receive radiation therapy unnecessarily. And there is information on their synthesis of 10 years of research on the effectiveness of mammograms. That is frightening, Shiloh. Now I'm afraid we're going to have to go back to some math, but math has been done by the Cochrane folks. If we assume that screening reduces breast cancer mortality by 15%, that's a generous estimate. And if we assume that overdiagnosis and overtreatment is at 30%, which is probably an underestimate, what that means is that for every 2,000 women who get screened for 10 years, one will avoid dying of breast cancer. For that woman, that's really significant and important. But in addition, 10 healthy women who would not have been incorrectly diagnosed if they hadn't been screened will have unnecessary surgery and radiation treatments. Also, women who receive what is known as a false positive finding, we undergo psychological distress, anxiety, years of uncertainty about our health status. And I know what Kirsten is saying. Oh, thank you. So there is that article. We need to know more about the NNTs of medical saves and false positive problems, including quality of life issues, for all recommended screenings in order to decide the real value for our future health. And there is the link to that article. Yes, that is a colonoscopy on the right side. Polypharmacy is a term that describes the use of 5 or more medications, and that's associated with adverse outcomes. If you're taking 5 or more medications, you're more likely to have disability, falls, frailty, and death as an older adult. And there's the research for that. The more drugs you're taking, the more likelihood that they will interact. Some drug interactions increase the drug's activity, some negate it. But many elderly patients have complex medical needs. So here's advice to doctors. While prescribing multiple medications cannot be avoided in a specific patient scenario, healthcare professionals should aim for a balance between overprescribing and underprescribing, and should consider medication appropriateness based on life expectancy and care goals. There's where that article appeared. And here's another article similar. Overprescription is another problem. This is a horrifying statistic. 3/4 of antibiotics prescribed for us elderly people are unnecessary. 3/4. Just think of the cost, let alone the medical implications. Often these inappropriate prescriptions were for illnesses that were not caused by a bacterial infection, which is what antibiotics work on. It could be they were given for a non-bacterial skin condition, a viral respiratory tract infection, or bronchitis. And what this does is it leads to the development of antibiotic-resistant bacterial strains. We really shouldn't be doing this. If you have a large prescription list, take this information on deprescribing to your healthcare team. There's a whole process called deprescription that medical professionals need to know about. Older people often have multiple health conditions. We are constantly considering opportunities and alternatives for handling the different challenges and situations that we face. Good, Kirsten. And that is true, Savannah. Older people with multiple medical conditions look for appropriate alliance partners to support them. It's very difficult to do all of this on your own. And we sometimes, I like this word, we sometimes circumvent the healthcare initiation of planned steps. We don't do what we're told, and we take different directions in our own care. And these considerations are often long-term. Achieving consistency between the healthcare system and our own decision-making process can lead to a more appropriate level of healthcare in line with the patient's preferences and goals. And there is that article. So what can you do to help manage your multiple health issues? Understand your options. Find someone you trust to help you in decision making. And keep your healthcare provider informed as you learn more and make decisions. You want to know what treatment outcomes are most important to you, and be sure your provider knows that as well. You want to balance benefits and risks. You want to learn more about these NNTs. You know yourself better than your healthcare provider does. Speak up immediately if a treatment is causing side effects or isn't working. That's really important. And be sure you understand all the instructions, because if they're too complicated, you can always ask your healthcare provider to explain more simply. Every medication has side effects. There may be non-medical options that you would prefer to try first. Look those up. Do your research. That is especially true when you're dealing with symptoms. Many of the medications we take are for symptoms, they're not for conditions. There's some information about that. I'm going to end with some resources here. The Decade for Healthy Aging, which we're in right now, provides the opportunity for concerted and coordinated initiatives to improve our mental and physical capacities and offer an age-friendly environment to enhance the functional ability of all older adults. And there is a link to that information about the Decade of Healthy Aging. And here's a summary of the advice that I've offered. Be aware of changes in your health. You know yourself better, and you can be your own best advocate. There's information on how to be your own best advocate. Remember, healthcare is a business. It's not a service. You need to remember to think about who's making money from the recommendations that are being offered to you. There's some information on that. You need to read about medication side effects. Your pharmacist is a good place to go for that information. And you need to do research. Don't go on common sense. Look for validated research results. And to find peer-reviewed articles, PubMed is good. I use that a lot. If you want to skip all the individual research articles and get a compilation of research, Cochrane is real good. And so there's the Cochrane one. And James is offering some information. You can be prepared to balance your risks and benefits to make informed choices. I love this site. It's called The NNT, and it has NNTs about all kinds of things, and it's written by doctors. So most of all, take good care of yourselves, people, because there is no do-over feature in the game of life. So I want to thank Whole Brain Health for sponsoring this important conference. I want to thank Lucena for inviting me to take part. And we have a very short time left for questions and comments. Aren't you glad I took half of my presentation out? I'm out of breath now.
Wow. Yes, we've got more to go, which is wonderful. We've got something to look forward to. James, would you mind not putting more things into the chat that have nothing to do with the conference? Right now. Thank you. Okay. Yes, please, anybody have questions, comments?
Oh, yes. I could talk about allergies too. Sure, Kirsten. Go ahead, Kirsten.
You can talk. You can use your voice, Kirsten.
Okay. There was one point that you made there, well, twice you made it, and it is worth every minute of it. In my team, I have a complex situation. There is one cardio specialist, one, who actually discusses my treatment and my medications. And 3 years ago, I told him to take off the blood pressure. I didn't need it. And he just looked at me. He says, okay, but let's make a deal. If your blood pressure runs X 130, 3 days in a row, you'll go back on it. And I said, fine with me. It's never gone above 120 in these 3 years. He's the only one that will listen. And when I came up with another complication, I now know how to go through the NIH inside out, and I'm one of their research subjects. I went there, and they only knew 7 triggers for this particular genetic disease, only 7. 2 of them were under my cardiologist treatment. I took him to that, and he said, what do they know about it? And I said, only that it can trigger. And I'm trying to do this without medication. I don't want to have to take medication because I can treat it with foods that I stop eating. And he told me, okay, looking at the 10,000 foot picture, We can let go of that one too. Keep track of things. But out of my team of 5, I have one doctor, but I gave him a chance to discuss with me, and he did. So the points that you've made here, oh man, he's going to get them all. He's going to get them all, and I know he's going to share them with others because I have 2 other doctors that are very stubborn about treating me like I'm an intelligent person, which reminds me I need to go to Darth's talk. But yeah, you've got to advocate for yourself.
Oh, you do. One of the things that I think is most problematic about blood pressure is that most of the time when our blood pressure is measured in the doctor's office, it is done incorrectly. And it's a higher reading than is normal for you in your daily life. They're not doing the blood pressure readings correctly.
I got an Omron Gold. If anybody can do this, I got an Omron Gold. It stores my readings. I take them at the same time every day. And once a week, I download them and send them to him so that he knows. And he doesn't even question anymore. But I do send it to him. That was one of the things that I did, to reassure him about my blood pressure. I knew I didn't need blood pressure medication. But like you said, with the pharmaceuticals and that, it is simply, he called it prophylactic treatment. And I said, I don't need protection from this anymore, okay? I don't have high blood pressure. And he took me off of it, and he said, I trust you. Took me about a year of talking with him to get to that point. But he's trying to help the other doctors to listen to me, too. Thank you so much for bringing that out and giving me all this wealth of information I can share back to them and say, I told you so, I told you so, I told you so. Thank you, Gray.
I don't mean to get anyone in trouble with their doctors.
No. You're helping me make the point that they want to believe, but they need to have it proven to them.
Right. And many doctors don't have the time to read all this stuff.
That's actually true. I recently gave my doctor a couple of articles to read, and she did actually read them right with it when there with me. She didn't do it before, but right there with me, she read them, and she said, "Oh, okay." And I think,
And see, that's why I try and give you articles that have an abstract or a summary, because that gets to the gist of it. You don't have to read all the statistics and all that stuff. You can, and I think it's important for somebody to read that stuff. But if you're short on time, or if you are scared of math or whatever, just read those summaries.
Gentle, how much would you say that whenever I've been prescribed anything from a doctor, I always ask my pharmacist first, should I be taking this drug and what the side effects are? How much do you recommend that people interact with their pharmacist a lot more in order to get accurate information as to side effects and the utility of a drug?
Personally, for me, my pharmacist is my primary source of information about medications. The doctor prescribes, the pharmacist explains. That's for me. And Margot, I understand that. It is problematic that too much is published in English and not in other languages. There are translation tools. Translate the abstracts. Translate just the summaries. That's just a few paragraphs, but it gets to the gist and the point of it. And there is research in Turkey. So far, I haven't been able to get anybody that I've invited from Turkey to talk at our conference, but I continue to try. Well, thank you all for your attention, and very good luck with your continuing healthcare journey. I know there's another session coming up right now.
No, we have a musical interlude with Ari. So people can go there. I'll put that into the local chat for people. And I'm holding you to